morning, everyone.
Good morning.
I'm Jamali Martin, and I'd like to welcome you to what I believe is our last seminar series for this year for the Center of Global Health. Just to let you know, we are being recorded, so I hope everyone's okay with that, because we all want you to stay. We don't want you to leave. But I would like to introduce our seminar speaker for today. Oh, and this recording will be posted on the CGH website in spring. So our seminar speaker for today is Dr. Patrick Laura. He's the director of the Melvin and Bryn Simon Cancer Center at Indiana University. He's a medical oncologist by training. He's also the H.H. Gregg Professor of Medicine. And he is the founding director of the Ruger Oncology Group. Did I say that?
No, but I love it though.
You want to see how I sound my H's as a Caribbean, with my Caribbean accent. So, he's done research in GU, GI, and thyroid cancer, so I'd like to welcome him as a speaker today. I really look forward to your presentation.
So I'm going to start just by saying something totally inappropriate. I love you. So that's a take-home point. Just remember, for all of you who forgot today is Valentine's Day. Yeah, right. You don't care, but your husband does. Just remember someone today. Tell them the same words there. That's really the most important thing I have to say today. I'm so grateful to have the opportunity to speak here to all of you, Centers of Global Health, about our work that we've begun in Kenya and Eldoret. And so what I'd like to do basically is talk about a model of what we have been doing in Kenya with the hopes that we can begin a dialogue and I can learn from all of you. Let's see here. So how do we do the page thing here? The arrows don't work, huh? So I push this.
Yeah.
Got it. This is a picture I took. I'm very proud of this from Lake Nakuru. That gives kind of a background of what's going on. So there's certainly lightness there and there's dawn, but it's also, there's a lot of darkness of stuff that we have to do. What I want to do is talk a little bit about the background and how we began to build the oncology program there. And it really was built on the backbone of a partnership with what we call the AMPATH program, which started about 25 to 30 years ago, which was on the platform of HIV/AIDS. The AMPATH program originally stood for the academic model for the prevention and treatment of HIV/AIDS, and more recently they've changed the nomenclature to focus more on chronic care delivery. It's an academic model for providing access to health care. There are, in the AMPATH model, based on what has been done over the years, it's truly remarkable. And this was a program that was begun by Bob Einturns, Joe Mamlin, and Charlie Kelly from Indiana University. And it started as many programs do with a partnership with a sister institution. And these physicians went over to Kenya. They picked it because there was a formation of a new medical school that was going there. And they were just going to spend some time there and see what they can do. And in the midst of all this came the HIV crisis. The story goes that Joe Mamlin, who was the former head of medicine at Indiana University, was over there for a sustained period of time doing rounds and with the medical students, and he saw this one patient who was weighing something like 65 pounds, and after the rounds, medical students hovered around this patient, and he asked who this patient was, and it turns out it was another medical student who had HIV/AIDS, who was dying from it. And so Joe was so moved by that, he sent back an email back to Indiana, and finally some funds came, and they were able to give this patient some antiretroviral drugs, resurrected this guy, and he's now working on the staff of at AMPATH. But through this process, they recognize that it's more than just giving medicines. They really need to work on other aspects of stuff, including nutrition, because this person was so nutrition depleted. So on this program, based on Leading with Care were patients who had HIV in which they were able to get antiretrovirals for them. But they also recognized they needed to build a program built around nutrition, and so they created farms, which patients were given small plots of land, like 3 feet by 3 feet, enough to feed themselves. And when they got stronger, they got larger plots of land, enough to feed their families, and actually sell it back to the hospital, which brings up the other point of sustainability of income generation. And they also created workshops in which the widows were able to work to make beads and other utensils. They created a juicing work. They had a lot of experiments and things. But recognize that if you're going to make a difference, it's more than just dropping in medicines. It's really going into the system and really trying to change it. So over the period of years, and particularly with help from PEPFAR, they've been able to create a model for HIV/AIDS that is, I think, really a model for the whole world. They, a few years ago, started screening pregnant women for HIV, and the maternal to fetal transfer of HIV is, I think, less than 2%. It's really something extraordinary. They screen hundreds of thousands of people for HIV annually. Through the food program, they have 3,000 people who are fed weekly, 30,000 people who are fed weekly with the food program. 10 tons of food are grown weekly on these farms. They serve the orphans and the vulnerable children, which are an important part of this epidemic in which many mothers and fathers have died. They have used technology now where they can go into the homes, into the huts, and do local HIV testing, and then they click a button and they have a GPS device and they know exactly where this person is, and they can give them an instant report of their HIV testing. Through donations, have created a mother and baby hospital as well as an AMPATH center for chronic care. And through partnerships with various departments at Indiana University as well as other institutions, any time you go to Eldoret, there's probably about 50 people from North America from various different institutions who are there in various different disciplines, including OB/GYN, cardiology, infectious disease. And it's truly a multicultural, multi-institutional program. So that's the background. So in terms of the cancer program and where we need to go, this was an article that ASCO had a leadership development program that was initiated a few years ago, and it's part of the program. People were given projects, and the group I was with, we tackled the role of ASCO in low-to-middle income countries, and this was published about a year and a half ago by our group here. But basically, these are the things that everyone in the room knows, and we stated in the article that the barriers to cancer control in low-to-middle income countries have to do with the lack of infrastructure. The workforce is poorly trained and limited. We were talking about the care delivery in Africa is largely done by nurses, and again, very few nurses are trained specifically in oncology, and fewer yet are physicians who are trained in oncology. The cost of patient care is huge by our standards. When you think about trying to use bevacizumab for the treatment of colorectal cancer in sub-Saharan Africa, it's laughable. Because these patients can't afford 5-FU. And I still remember a patient coming in the clinic who had a bad cellulitis, and he was given a prescription for Teflex, which cost the equivalent of maybe $1. And he came back 3 weeks later, the infection was worse, but he couldn't afford buying the antibiotic to take care of his cellulitis, let alone chemotherapy. By and large, there's insufficient attention paid to palliative care, and again, most of the patients who are presenting with cancer in Kenya and sub-Saharan Africa present with chronic disease, for which palliative care becomes an important component of their care, and yet many of the governments, as you know, don't even supply morphine, and that was an issue that was there. And then the education deficits, and this is not only for the professionals, but also for the lay people. For them, cancer is a curse that was given to them because someone in their family offended someone else. They had very little understanding about the knowledge of what causes cancer and how it can be effectively delivered. the first visit to Kenya a few years ago, it was about 8 or 9 years ago now, I went there and immediately landed, and then I went on rounds. And I did inpatient rounds as well as outpatient rounds. And my outpatient rounds, this was one of the first cases that I saw, and we just recently did this at our ASCO course as a CPC for the group here. And so I'll just show it to you. It's a little bit symbolic about some of the issues that we have in cancer. So this was a patient I saw, a 25-year-old man presented with a pathologic fracture of his distal humerus, right radius, I'm sorry. He said that he fell down a few years ago and injured it, and then about a year before I saw him, he had re-injured it and came in to see the physicians. They saw this looks like a tumor. They biopsied it, and it was read out by the pathologist as a non-Hodgkin's lymphoma. So he got treated with Cytoxan, Adriamycin, and vincristine, which is we typically in a lymphoma would do those drugs plus prednisone, but he got treated with this for 3 cycles. This mass didn't change, and he came into clinic that day to see us, and he carried his own x-ray with him. This is a picture of this patient. Now, for the physicians in the audience, this is not the typical presentation of someone with a non-Hodgkin's lymphoma. And so for the non-physicians, I can apologize for showing a picture of this around breakfast time here, but this is a very significant picture. Now, he brought his x-ray with him. Back then, well, that's my thumb there. I held the x-ray up to the window. My thumb has gotten fatter over the years, by the way, but held the picture up to the window there. And what you may not appreciate from the distance, but if you look carefully, there's a little bit of elevation of the periosteum here. I don't know if you can appreciate that. You guys see that or no? Faint little line there. And so this is a classic sign that again, us older physicians know, called Codman's triangle, which is almost pathognomonic for osteogenic sarcoma. So I, again, made the suggestion that this was probably, probably osteogenic sarcoma, and recommended doing amputation. And about 6 months later, when I came back, his arm indeed was amputated. Indeed, it was osteogenic sarcoma. But
excuse me, is osteogenic sarcoma have that leaf sign in it?
The
leaf sign.
I don't know what the leaf.
Go back.
Yeah, I had no clue how to go back on this one here.
That's okay. That's a joke.
It was a joke.
There were leaves outside the window that you were holding up to see.
You're right. There is. It is. No. And because this is being recorded, what is your name? We can fill this in later there. So, the little thing, there's no such thing as a stupid question. There are exceptions to every rule here. This is an example. This is one of our outreach clinics here that I took a picture of, again, several years ago. And again, here's a tent. We went there. If you can look at this, you can see actually, so patients are getting chemotherapy here. The needles are here. They can discard them in this tube, but a lot of them actually, at the end of this clinic, there was just a big pile of needles here and syringes as I gave the chemo and threw it there. It was, pretty amazing to see this. The infrastructure in Kenya for cancer is really quite poor. By the way, Nairobi here is the capital of Kenya. Eldoret is about 4.5 hours by car here to Northwest, and it serves an area here of around 20 million people here in Western Kenya. There was a question about whether or not there was a cancer control plan, and this was a policy brief that was presented about 2 years ago now. The infrastructure in Kenya at the time we started this, there was no national cancer registry that was present. There was no national screening program for breast cancer, cervical cancer, any other cancers for that matter. They had 2 cobalt units for radiation therapy, both located in Nairobi. When I visited this in Kenyatta a few years ago, one of the machines was working and the other one wasn't. There's a backlog of around 3 months for patients who were seen before they would get radiation therapy. In terms of the total country, there are probably 3 or 4 oncologists, and I have to use that with parentheses because most of the people who were trained in oncology were really not formally trained in oncology, but rather were medical officers who took an interest in oncology and became oncologists. As far as I know, Dr. Aswara, who is a fellow who trained at Indiana University, who is there now full-time, is the only specialty-trained oncologist that is in the country. They had a few radiation oncologists that were present there, too. This is at our AMPATH oncology program. This is, again, we don't have the facilities to be able to deliver chemotherapy as an inpatient or even inside of the building here. So we placed a tent outside. Chemotherapy is on here. And actually, although this may look a little tough, this is so much better than it was years ago. As you can see, patients, the nurses who are administering chemotherapy are wearing gloves and masks as they get the chemotherapy. And their preparation is much cleaner than it was before. We actually have a hood in which chemotherapy is prepared underneath the hood. As far as I know, this is the only one. In terms of the pathology infrastructure, back when I came there about 7 or 8 years ago, there was really very few patients who were biopsied. It was mostly based on visual diagnosis. If they did do a biopsy, the turnaround time was 6 to 8 weeks. They would give you a gross characterization that might say cancer or lymphoma, but they wouldn't be very specific because immunohistochemistry staining was not possible. And they really had a lack of a functional cancer registry. And this brings up a point, I think, particularly as you're looking at incidence of cancers there. It is less than half of the patients that are seen with cancer in Kenya today have a pathologic diagnosis. And so when one looks at tumor registries, it really is understating the enormity of these malignancies. One of the reasons for that is that the best example I can give is at Kenyatta Hospital when I visited there, less than half of the patients there had their pathologic diagnosis made, but a patient may come in the hospital and have a tumor resected, make believe it's a breast cancer. The surgeon would put this in a Cool Whip container, maybe with a little formalin, and then give it back to the patient and say, if you would like to have this read, there's a private pathology lab outside. Now, but it's going to cost, $50 to $100 to have this read. So most patients, unlike in this country where you think about it, most of them say, listen, I really don't need to have it read. You've told me it's cancer. Why bother with it? And so very few patients end up having their histologic examination done. And when it's done, it's again, the sensitivity is suspect. More recently, we've instituted a program, particularly with the IDEA program, and Jeff Martin, we instituted a program with everyone with Kaposi sarcoma, which never got biopsied. We do punch biopsies and trained our nurses to do it. And at least at Moy now, this has become an accepted standard. I would say about 80% to 90% of patients now have a pathologic diagnosis of their cancers. The turnaround time is much better, but still it may take 2 or 4 weeks to get the results. We have begun using immunohistochemical stains. Again, this is very expensive for them, and so we've been trying to help them out as best as we can. And we do have a registry now that is run by pathology that's fairly up to date. Back when we started here at AMPATH, seeing patients here, we saw just a few hundred patients visits a year for oncology, and we're well over 10,000 patients now a year that we're seeing in the program. Initially, all of the patients that we saw, virtually all the patients we saw, were part of the AMPATH system, so they're age-related malignancies coming into our system. And because of what we built there, we're seeing more and more patients who have non-HIV-related malignancies. Because of support that we've had from Pfizer particularly, in which they gave us unrestricted dollars to buy generic drugs, we've created a treatment plan so everyone that has a curable cancer gets treated. All those who have a treatable cancer, most of them get treated. But if they have a refractory disease in which chemotherapy has very little hope, we typically don't give them chemotherapy unless they pay for it out of pocket. We have created some standardized treatment protocols for the physicians there so they know how to follow them. But one of the concerns that, again, I'd love to have a dialogue with you, is the problem with sustainability, because it is impractical for a company like Pfizer or any other company to donate enough funds to take care of the cancer needs for an entire country. And so we've got to figure out a way that there is a mechanism to help increase the funding for these, to allow treatment care.
Do you have any idea what that number is right now? How much dollars you're spending a year?
Oh yeah, we're spending about $300,000 to $500,000 a year on chemotherapy. Yes.
Thank you.
And again, it's amazing. The treatment of CHOP, to treat 4 to 6 cycles of CHOP is probably around $400. Whereas here, that hardly gets you out of the door with the oncologist, let alone paying for the drugs. I think a very extraordinary program is our gynecology oncology program, which has been led largely by our colleagues at the University of Toronto, Dr. Barry Rosen, who's head of oncology there. University of Toronto has put on ground one of their faculty who has been there for about 3 or 4 years constantly. Dr. Orengo or Dr. Omenge he's a Kenyan, spent time and did an observership at Princess Margaret Hospital. They had some funding through the Fogarty grant in which they did a study comparing the visual inspection with acetic acid to pap smears and found that VIA was much better in terms of feasibility of doing this, and particularly the turnaround time. I will mention there was a screening procedure they did several years ago in which they had a bunch of women came in and did pap smears. A year later, they still hadn't read all these pap smears on the 100 women who had had the exam done. And so the VIA, you can get instant results. And as a result of all this stuff, they've agreed to increase the screening program. And this is actually a picture. Barry Rosen is the fellow here in the middle here, and this is Dr. Omenge and his colleagues there. This was the first abdominal total hysterectomy that had ever been performed in Kenya, and this was done a few years ago. And now I think they're up to 75 hysterectomies that they've performed, and they're getting ready to publish this experience. But the mortality rate and the morbidity rate is just comparable to what they're seeing in Canada. But they hadn't been trained properly on doing this. But I got to give just great kudos to Dr. Rosen and his colleagues, because they've done some wonderful exchange programs in Canada and back and forth. And Barry is there. I just left him there. I think he's still there. He's been there for about 6 weeks, putting on ongoing training programs. We were just there a couple weeks ago, and there was probably about 30 or 40 healthcare professionals. He was teaching them on VIA and doing colposcopy. Again, is there any gynecologist? I don't know much about this stuff, but they actually they brought in some chicken. And so through a long tube, they were teaching them how to do biopsies of the chicken, which simulates, I guess it simulates what they see in women when they do. I don't know how it goes there, but that's their interpretation. But these guys have undergone wonderful training, and it's really an extraordinary event. I met with a few of the nurses several years ago, about 4 or 5 years ago, in a room much like this, and asked any of them had they ever had a pap smear or had a gynecologic examination, and none of them had. And just to show you how much they've done, they've now screened over 12,000 women here in the last few years, and it's really something that's just incredible of what they've done. They've treated over 300 people with cryotherapy, and they've done the LEAP procedure on 250. They're now detecting cervical cancer at much earlier stages, which is terrific, and in some cases, but obviously by using cryotherapy, hopefully they're preventing it. But one of the crises, if you will, or one of the moral imperatives when you're doing the screening is it's not enough to screen patients. You've got to have some treatment for them if they have advanced disease. Because the patient population in the community, all they know is that their mother came in for a screening, they were doing fine. Suddenly now they've got cancer and they've died from cancer. And so we've got to have the backup infrastructure for this, and there's got to be care. And so they have done programs just using single agent platinum. Cisplatin And actually, it's amazing, they've seen great remissions just with single-agent therapy. What's missing at Eldorado is that we have no radiation oncology, and so this has been one of my strong causes over the last 8 or 9 years of trying to get that going, and we'll talk about that in a little bit. A year ago, Dr. Rosen and Dr. Aswara and the members at MOI proposed a gynecology oncology curriculum, which was approved by the government of Kenya, and that has just been instituted in the last few months, and this is the formal training, which is one of the first multidisciplinary programs in the country. As a medical oncologist, we have so many drugs at our disposal in this country, and the cost of care for medical care in this country for cancer is, again, something that's extraordinary also. The beauty of thinking about going to low to middle income countries is that it causes you to reflect a little bit. And if you had a doctor's bag that you're going to take with you to a country and say, okay, which drugs do I really, really need? You suddenly realize that a lot of the drugs that we use in our day-to-day practice are not particularly drugs that are incredibly useful. Bevacizumab, which may prolong the survival in metastatic colorectal cancer by a few months, probably not real practical here. Whereas some of the older standby drugs, such as 5-FU or Cytoxan and Adriamycin and vincristine, drugs that are generic drugs that have had a huge impact on the treatment of the curative of many common diseases, are drugs that you'd want to have in your bag. And so as we do a lot of work, as we should in targeted therapy here, again, the balance in this country is to think, okay, what are the key drugs that you really, really need to have? Donations of some of these drugs, for example, let's take imatinib for the treatment of CML. Every once in a while we'll have some people, I've got some imatinib, I'll give it to you and donate it. What good does 2 months worth of Gleevec do in the course of a lifetime of someone with CML or with a gastrointestinal stromal tumor? So they get a brief remission, but then the cancer comes back again. And so again, gets back to the sustainable things and what you can do. So we have to focus here in this country about curative therapies. There are diseases in which you can have prolonged survival and metastatic disease, and obviously we want to do that. But again, it gets back to it. Is it really worthwhile really having an impact if you have someone with pancreatic cancer to give them gemcitabine, which costs a fair amount of money, knowing that the total impact on their life is measured in a matter of a few weeks? In this country, we do it without thinking. There, we've got to think, and we've got to do some triaging. It's important also to think about minimizing toxicity for these ones. The other aspect is it brings you back for an old fossil like me to the roots of medicine back in the 1970s and 80s and 60s. Of just being a doctor and being a good doctor by listening to art and doing an examination. If you have a lymph node in the neck, you don't need to get a PET scan to see whether or not there's going to be a response. Did the lymph node shrink after you treated them? There was a patient that was almost went to surgery for pancreatic cancer. They somehow got a CAT scan on this person. Again, for the old physicians in the audience, there's different kinds of syndromes, if you will, with pancreatic cancer. You can get a Burkhouse node, which is a lump in your left neck. There's a thing called the Sister Mary's Joseph nodule, where you get metastases around your umbilicus or your belly button. And sure enough, as I did this exam on this patient, she had a mass and an umbilicus, so it already had metastatic disease here. And so just by doing a good physical examination, without having CAT scans or PET scans, I was able to avoid a surgery that would have been fruitless for that patient. Oops. Palliative care, as I mentioned, is an important component of this. It got started in the fall of 2010. There's clearly a growing need for this. And we have a number of different physicians, particularly Greg Ramelsbacher from the University, Colleen Brown, who have instituted a program there. And on site, we have a palliative care doctor who just recently is moving to another country, and I think we've just hired a replacement for her. But this palliative care team has seen up to 6,000 patients a couple of years. It went from just a few hundred to thousands of patients that are seen. And the non-oncology wards are now asking our palliative care team to get involved with them. So I'm thinking about capacity building and how we might, from the West, think about the low middle income countries. These are some of the questions when we see a patient. First of all, when a patient presents with a mass, there's some questions you have to ask. In this country, we just do it without thinking, but first of all, is it cancer, and can we biopsy this lesion? Is it a situation that we can actually get in there and do this safely? But it's a little bit like a testing, though. If you're going to move this piece and do the biopsy, the next step is, if it is a cancer of the type you think, are we going to treat this patient? Is it a patient who his performance status is so poor or so advanced that it's unlikely that you're going to have a benefit? Similarly, if we're staging the patient, how do we stage them? Again, we can do it with various different radiographic techniques. But each test we order, these patients have to pay out of pocket for a CAT scan, for even for mammograms, a simple mammogram, they would have to go to my so we have to figure out if our staging makes a difference in terms of what we do. Next question is, can we treat? If we identify a certain kind of tumor, do we have the surgeon who's capable of doing this? And as we treat them, are we doing the right appropriate thing? One of the issues I had at one of our tumor boards about a year ago when I went there was a woman they presented who had actually it's funny, my voice is starting to crack, so I do, does anybody have any Poland Springs water? But they presented with a 10 centimeter breast mass, and at the tumor board, the surgeon made the recommendation of doing a lumpectomy. Now, you don't, again, I'm not a breast cancer doctor, but you don't do a lumpectomy on a huge mass like this. And if you did, you would do it with the idea that you would give post-operative radiotherapy to help minimize having a local recurrence. Well, in Western Kenya, there's no radiation therapy there. And so why would you do a lumpectomy knowing you'd have to give radiation when you can't give radiation? So we presented this concept a couple weeks ago at a conference we had in Kenya, and they brought up a very important point, is that this woman, if you removed her breasts, she would be disowned by her husband, and then she would be left on the street. And so physicians there are then in this little perplexing situation of do I just let her cancer grow, or do I do a procedure that's probably not optimal, but yet it's going to at least have some impact on the patient? And so these are some of the situations that come. And finally, with all these patients, how do we pay for the care, and how do we develop something that can help them be sustainable? So in terms of the essential steps for oncology measuring success from the London Declaration, there are a number of different factors: cancer surveillance and having a national cancer plan, prevention programs, early diagnosis and screening programs, treatment programs, palliative care, and training and research. And we've been fortunate in Eldoret, at Moy, and AMPATH program, basically to have all of these covered. Probably the weakest link has to do with prevention, and we would love to get into doing HPV vaccine therapy, because I think we have the opportunity to do a lot of things. One of the initiatives that we're doing in AMPATH is this FLTR, or Find, Link, Treat, and Retention. And their goal for HIV is to do this with 2 million people in the catchment area of Western Kenya. And in order to do that, we have to tackle questions about linking the patient up with healthcare professionals, oftentimes nurses, and retaining them in the system. It's not enough just to diagnose cancer and have them go away, or diagnose HIV, but retain them so that they come back. We've got to measure the impact of cost of care and survival as relative to this early detection. And I think the thing that comes to mind easy for me, and probably most of you, is to think about women's cancer, and particularly cervical cancer and breast cancer, in which we can, if we can detect it early, I think we can have a huge impact. We also have to study the impact of these kinds of chronic diseases on the family members and the friends, the widows. We have to understand the economic status of having this particular kind of disease, what it does to this family. I was talking to Lisa earlier today. HIV, you're put on antiretrovirals and you're on these therapies for life as it stands today until a vaccine comes out. With cancer treatment, particularly for curable diseases, say they have Burkitt's lymphoma or another non-Hodgkin's lymphoma, this is something where you can treat for a finite period of time and actually cure these patients. And so it may cost $500 to cure a patient from cancer. And knowing that, then, can we leverage this and work with microloans to figure out a way to make this more sustainable and access to this. So the stretch goals, these are some of the stretch goals that we have. One is to stop cervical cancer deaths, and I think we can do this in Kenya, much like they've done with HIV, particularly if we partner with HPV and get the vaccines there. The political and the religious objections of HPV vaccine are not strong there as they are in this country here. It is the #1 cause of death in Africa, by the way, cervical cancer. And although cervical cancer deaths occur in the United States, there are vanishingly few people who die from cervical cancer in this place. We want to reverse the presentation of locally advanced and metastatic disease for breast cancer. Again, I'm old enough to remember back in the 1970s when I started my medical school training of women who came into the clinic with huge masses, fearful because they knew they had a lump, but if they went to see the doctor, they would undergo surgery, and they may wake up after surgery with a radical mastectomy, with a huge scar, or they may just wake up with a Band-Aid on there, and they just didn't know. There wasn't a communication going on there. So there was a fear of women coming in for care back in the 70s in our country, and this is much what's going on there in this country. And so, again, if we can work in getting these patients presenting with earlier stage disease, and if we have the capability with radiation therapy to help treat these patients and have minimally intrusive surgeries to these patients, it'll be huge. And this is something we've seen it, we know it can be done, and we can do it there. Yes.
That's a question.
Yes.
Related to HPV. And what about head and neck cancer? Are those also on the rise in Kenya?
Yes. That's a good question. So Hassan brought up the question about head and neck cancers. So it is, there's a lot of, I have lots of pictures that I didn't show in this presentation that I could have. But the patients present with a lot of different head and neck cancers. Now, the problem with pathology there is that formerly they wouldn't biopsy these. And so they might assume that it's Kaposi sarcoma, or maybe nasopharyngeal carcinoma, which is common because of Epstein-Barr virus. There also have Burkitt's lymphoma that can show up there. So we've got to get to a culture of doing biopsies on there. But squamous cell carcinoma of the conjunctiva of the head and neck area is common there, and so it is a big issue there. They haven't done a lot of work on HPV testing there of the oral. That was one of at our research conference we just had, that was one of the topics that came up. So in terms of screening and prevention, again, in this country we've done an okay job, but not really great. Most of the focus of oncology in this country is based on treatment, taking care of patients with advanced cancer, looking now in fourth-line therapy, doing biopsies to see what mutation is present. The biggest bang for the buck in terms of impact is going to be on prevention and screening, particularly in sub-Saharan Africa. We need to create reliable diagnostics. Again, the pathology infrastructure in the workforce is woefully poor. The number of patients who get biopsies are woefully poor, and so we have to work on those areas there. As I mentioned on a number of different times in my talk already, we need to create a sustainable treatment program in which all those patients who deserve and will have great benefit from treatment should be able to be treated. And this has got to be coming from partnerships with the government themselves to help working on the program. And finally, we have to provide palliative care to all patients with cancer. And again, this just happened this week with me. I had a friend of mine whose mother is 81 years old who metastatic disease, and I referred to hospice. Yet, the daughter didn't want her to go to hospice because mother to die. There's this peculiar thing in our country where you don't, this palliative care should be from the beginning of a diagnosis until death. It shouldn't be this stepwise approach where you're treating and then suddenly you're put on hospice. And again, in this country, we have a chance of doing it the right way in which we can begin palliative care from the beginning. And the other thing is actually to educate the public and let them know that that cancer is not a result of a curse, but there are real causes to why people get cancer, and these causes are things that we can. So in terms of creating a sustainable approach to cancer, I think, again, this is a little piece we put together for the Coleman folks, looking at the entire spectrum of cancer. But we go from the pre-morbid condition, the nutrition, the background of where the patients are. working into programs with cancer prevention and early screening and detection. We get into treatment and palliative care. Hopefully, we're going to have an increasing number of patients who have survivorship, and it's incredibly important for us to develop a growing number of survivors that can go back to tell the patients and families that cancer is curable. We can make a difference, and I am living proof of it. But ultimately, we've got to develop healthcare policies, and this is work that you guys are doing, working with the governments of all these different countries to help reinforce this area there. Let's see here. No, it's not working. Lost my connection, attempting to restore the connection to the conference center here. Oh, it got connected again. A line of connection going. So as we work on healthcare policy with the government, and they need to kind of address, again, as they did with the AMPATH program, let's look at nutrition, let's look at the economic development, because ultimately this will have an impact on this. What our model has been in AMPATH is leading with patient care. I think many programs in global health, if you will, we have a partnership with an academic person who goes to that particular country with a specific research project in mind. They do that research project, they've got their 100 patients with breast cancer samples, and then they come back here and they're happy. They think they've done something. But in our belief, we have to lead with patient care to create something that let them know that the research is relevant to them, and that when we leave the country, we've actually left them with a workforce that's capable of taking care of themselves, much like the Peace Corps model. Education is a critical component of that, and not only the education of the physicians, but also creating infrastructure education for nurses as well as for the community at large. But research for the North Americans is really the glue that pulls us into it. The reason academic people get involved is because they want to have some academic credit, they want to have research. The institutions will invest in this if they know there's some return on investment. And so the challenge for the Centers of Global Health, I think, is to make these partnerships work, is to have enough funds and monies to help support some of the novel research efforts to keep the glue. But at the end of it all, again, it ought to be centered for patient care. So the issues, briefly, I think I'm not sure how many slides, I've lost count of this, but workforce, again, we need to develop training curriculum for nurses, for therapists, for the physicians, particularly medical and surgical. We are building a new program of radiation oncology there, so we need to train radiation oncologists. We need to create a culture of academic models for the Kenyans or for low-middle-income countries, much like we do in this country. Let them know that research is important. Publications are important not only for their career, but for advancing some of the healthcare policies needed. We need physical infrastructure, infusion, as you saw. It's silly to be doing this stuff with tents. We need radiation equipment, and I'll talk about that in a second. The capability of doing screening is what we do for breast cancer screening now is with radiation, mammography and ultrasounds there. The drugs are part of the other infrastructure that's important, chemotherapy, the oral agents, supportive care, narcotics. And in terms of doing a sustainable research program, well, we know we need tissue banks to collect blood and tissue so that we do comparative studies, comparative genomics between our populations and theirs. A unique sidebar, if you will, is vincristine, which is one of the oldest drugs in oncology that's used. It wasn't until a few years ago that our investigators in the university found out how vincristine was metabolized. It was metabolized by 6 to 8 times. Most drugs are not metabolized that way. An interesting sidebar is that African Americans have more polymorphisms than Caucasians do. As a result, African Americans then get less neurotoxicity from vincristine, but they also get less effective. The drug levels are lower, the active agent. When we went back to Kenya, we looked at about 75 patients with Kenya. It turns out that over 90% of them have the same polymorphism. So here's the key drug vincristine. As we give to the Africans, turns out we probably need to double the dose of vincristine in order to reach the effective level, and we need to have better outcomes. So this is a lesson, again, that we can learn in Africa that can help teach us here. We need strategic plans, and this is around education, research, clinical care, and mentorship. This is not something that is native to the Kenyans. I think most of them have by themselves. We need to teach them how to be mentors, and in the process, we can be mentors. mentors. It's easy for us in North America to be mentors to them, but it really requires a responsibility, and it's not just a one project deal. It's really a lifelong learning that goes on. And these partnerships, it's got to be more than one-off. And to be honest, I think I've been fortunate just because of the positions I've been in. I was head of our division of hematology oncology, and so I could devote resources to do it. As cancer director, I could devote resources to do this. But at the highest level, it's got to be a commitment. The dean of the School of Medicine and many other departments are committed to this. I've been very fortunate with the University of Toronto, University of Massachusetts, Brown University, in which the faculty has also been very, very keen to doing this. And so this individual commitment is important. Having the institutional buy-in that they allow faculty to travel over there is very important. The other issue has to do with economics. And again, I was talking to Lisa earlier today. You know, we've got to figure out a way at the governmental level how to make this more and again, people smarter than I am. This is just an example. Last month I was just a few weeks ago in ANPATH, and all of this stuff happened within a matter of 2 or 3 weeks. We had a pediatric cancer conference that was led by our folks from Eldorado. We have at IU we have a pediatric oncologist who's on ground 6 months of the year, and people from Bree University, from Amsterdam came down. They come down on a regular basis and they host a conference. Thanks to Lisa and Ted, we had a grant writing workshop there in which we had 18 Kenyans present proposals, research proposals, and we had a team of mentors that met with these and helped them formulate their ideas. We had a leadership workshop, again, something foreign to them, give them lessons on how to talk publicly, and most of the lessons I taught them I'm not doing today. We had a multidisciplinary conference. This was the second consecutive ASCO multidisciplinary conference. They haven't done that before. We had 150 Kenyans show up for this one. It was just incredible. One of the things that I thought was very special was that we presented a case, a pathologic case, by the Kenyans. The case was, pathology had already been pre-reviewed by pathologists at General Hospital. Mass General Hospital pathologist was there, but online was the one who reviewed the case. So we had a discussion of all this and questions and answers, and this is going to be published as a case record in New England Journal coming from Eldorado. It's really, I think, will be very special. We did this via a colposcopy training workshop, and we had groundbreaking for our cancer and chronic care building. So this is next few slides, or this picture slide. This is a picture of our grant writing workshop that was helped to be sponsored in part by you for doing this. And it was an incredibly fruitful endeavor, although the lesson learned for me is that these guys aren't ready to write grants. We had wonderful presentations, but as we went through it, it was more of a project development program. We got them to think about projects and hypotheses, and I think we're going to have a number of different pilot projects that will come out of that, and hopefully down the road they'll be able to write grants. We had the train-the-trainer sessions, and these were a number of different topics. We had each of them get up and give a 5-minute talk, and they needed to sell something about themselves, and it was extraordinary. One of them gave a talk on how important it was, how surgery was the best specialty in the world, that it's the best. He's a surgeon and he loves, are there any surgeons in here? So he was saying surgery is so good, you know, and then he gave all the reasons why this was the best specialty, and then they sat down and I said, you didn't really look at your audience, did you? Because there are no surgeons here. And as soon as you led with that, we all lost you. And then he got it. We had another one who was going to be, he was running for office. He pretended to be running for governor of the province. And he did an extraordinary job of listing why he should be governor. We had this ASCO MCMC course that faculty from South Africa as well as North America. This was led by Chite Aswara and Hugo Villar, who's from the University of Arizona, and Vanessa Eaton from ASCO. Again, a wonderful course for this. Very proud of this. We had a groundbreaking ceremony for our cancer and chronic care building. And the ANPATH building is off to the right, which is where they do the outpatient center right now. And the space was cleared, and every boy's dream is to get on top of one of these trucks. So I was able to drive this bulldozer for a few minutes. So this is a architectural design of our new cancer and chronic care building that's going to be present here. And just looking at this, this is going to be the radiation bunker here, and the outpatient chemotherapy is on the first floor, which will be outpatient chemotherapy here as well as office space here. The second floor is shell space that will be for education and training. I would like to make this, my dream is to make this Coleman's Women's Center, so we can do our cervical and breast cancer screening as well as education materials. And then the top floor are going to be classrooms for us to do continued training. So my final reflections on this in terms of how we view things from Indiana University is that in global health care, in our perspective, must lead the way. These patients know that they have huge health care issues, and we need to go in there with an idea of helping them out. As I mentioned, education and research, I think, are glue to help us make this sustainable. But we have to go in there with the idea that we're in it for the long run. It's important for us to have strategic partnerships, and these partnerships are with key institutions, not only in across countries like this, but also within our own nation. And this is one of the few programs in which we have several different institutions going to one source, and this allows us in the flexibility of having expertise and faculty that can travel throughout the year rather than relying on one faculty member to get over there. You guys know this, but I have to state the obvious for people that aren't part of this program, but the inclination for us North Americans is that when you go to those low and middle-income countries, and you go there for the first time, you're going there to help them. It's very paternalistic, and you're going to go there and make a difference. And so you go over there, and you want to teach them everything that you know about what you know here in medicine. But the reality is that you go over there, you need to really listen. Bob Einturns, who runs this program, he's the Associate Dean of Global Health, said he was there for the first time for a year. It was 6 months before he offered any advice. And he said he would have waited a year, but he knew that he was only going to be there 6 more months, so he wanted to be able to do some things there. But it's really critical to listen, and really listen. Look at the environment, look what's going on, and be amazed at what these people are doing with so little resources, and ask yourself, are you able to do the same thing? And then when you watch this for a while, again, I think what you're going to find is that you're going to learn more from them than anything that they're going to teach, than anything you're going to teach them. The academic mission in all academic institutions is typically tripartite. It's service or clinical care, it's education and research. And again, we believe very strongly that this academic model is really what will lead to sustainability in many of these different countries. And if we can, again, encourage those institutions to embrace the same academic model, looking at all three of these missions, I think it'll be strong. And again, I believe that the AMPATH model is really one such model. I want to close just by tying in what I said at the very beginning, and how it has to do with love. Again, I'm crossing the line here, and I apologize here. But C.S. Lewis wrote a book called The Four Loves. You ever heard of C.S. Lewis? He did The Lion, Witch, and the Wardrobe. And he wrote a book about four loves. And one of the loves is the top love, if you will, called agape, which is God's love for the world. There's also eros, which is today is what some of you guys ought to be thinking about. It's more erotic love, or love between, people that are in love. The two other loves, one is paternal love, and then the love of friendship. Interestingly, C.S. Lewis, in terms of all of these four loves, thought that the love of friendship was the most important thing. And if you do readings about C.S. Lewis, it turns out that he was best friends with Tolkien, who wrote Lord of the Rings. They would get together. There was a little guys club that got together in Oxford, and they would just talk about things. And I'm sure, I can imagine C.S. Lewis said, I wrote The Lion, Witch, and the Wardrobe, and Tolkien, yeah, but I wrote Lord of the Rings. But the ability of having friends in which you can take great joy in them without really without reflecting yourself is an important aspect of things. There is a notion, I think, again, for North Americans to have more of this paternal love in terms of going to these other countries. And I think, again, that's nice, noble, but if it's going to be sustainable, it really has to be built on friendship. It's really got to be developing friendships with colleagues across the seas, realizing that they have great talents and abilities, and take great joy in seeing them present at national meetings, have them present at their conferences. And it's not about you, and it's not about just doing something for them, it's really doing something with them. And I think all in all, again, I think this is probably a nice day on Valentine's Day to think about friendship. And thank you so much for your attention, and happy to answer any questions.